Hello, good morning, everybody. Good afternoon. It depends where you are. It's really a pleasure for me to welcome you for this new webinar, which is a critical view of safety in laparoscopic cholecystectomy, organized by Bernard Dalmain from Belgium, Nat Soper from United States, and Andrew Gums from United States. And we will have also two fellows who are going to concentrate all your questions, and that is Pietro Mascani and Rita Rodriguez Luna from Mexico. So before the webinar, I would like just to take 2 minutes to introduce again IRCAD and to explain the concept of IRCAD that certainly you know, but we need to welcome you again really physically in our institute. So we have today 3 big auditorium connected to different operating room in the world. We have an experimental lab, and we work on simulators, on cadaver, animals lab, and also a very nice center of robotic surgery with today 13 Da Vinci robot with the last generation of XI robots. And also we organize not only laparoscopic course, robotics course, but also flexible endoscopic course, because it's something very important for the surgeon. Just a word also, because now we are totally ready to welcome you again in a new building that is an extension of IRCAD, totally dedicated to robotic surgery, a new auditorium of 250 seats, and a wonderful lab for different robots from Medtronic and CMR. That is the view of the auditorium, a new one, really totally interactive. That is a new operating room. A word about WebSurge. Please really connect to WebSurge because it is free of charge. It is translated in 7 different languages. And really, it is a fantastic virtual university, totally dedicated to minimal invasive surgery. And as you see today, we have more than 430,000 active members all around the world, regularly connected to this website. If we welcome you, we have also our own hotel and restaurant. That is a fantastic building of Louis XV of 1755 with a brasserie, with a 3-star chef. And you see, everything is really done to welcome you. And that is an extension of our hotel that we just finished now. Some weeks ago with really fantastic rooms. It is 50 meters from the institute, and you have everything. You have a nice room, you have a possibility of massage, you have really a very, very nice environment. So now just to finish, to say that we have a lot of IRCAD in the world today, in Taiwan, 2 in Brazil, in Lebanon, in Rwanda. It's going to be open in 6 months. In China, it's going to start in February for the construction in Wuxi. So thank you a lot. And I think it's time for the webinar, but really I want to point out how important it is when the COVID will be finished to welcome you physically in IRCAD. You will see that it is an exceptional environment. Thank you very much for your attention. And now I think that Bernard Dalmain is going to speak about the different topics of today.
Thank you very much, Jacques, for this very nice introduction. So as Jacques is saying, we're looking forward to welcome you in IRCAD because indeed it's a very nice environment. So welcome to this new webinar, back to school, early January, Happy New Year. But we have to go back to work, and that's why we try to organize this quite new concept, in fact, because we will just focus on critical view of safety in cholecystectomy, which is a quite popular topic. We are very pleased to have major contributors to this afternoon session. One is very important, is Nat Soper from United States. Nat Soper is one of the two guys who develop and validate the concept of critical view of safety with Strasberg. So I'm very pleased to have Nat with us. He's a very good friend, but also because of his expertise in this domain. I'm very pleased also to welcome a new partner for IRCAD, is Andrew Gums. Andrew is from United States, used to work in MD Anderson in the United States. And I don't know exactly why during the past 4 years he moved to Europe. Maybe you can imagine. And so it was working in France, and I don't know if he's going to be back in the United States in the coming days. I think 2 weeks left. So thank you very much for being with us. So he's an HBP surgeon, so very important also to have the input of this specialist. Together with me, I have Pietro Mascani, who is a fellow here on IRCAD. And Pietro is a fan of CVS. He's working on the development of some artificial intelligence support for cholecystectomy. So it's a very important work, and we'll see a little bit what's coming from that. And on the other side, we have Rita Rodriguez from Mexico. He's also a fellow surgeon from Mexico, working here in IRCAD and also working on the project of cholecystectomy. So this is a very important topic today in our program of research here in IRCAD. So new concept also, because we've never tried that. It's like a class. We will go through lectures, very few lectures, but I would say practical exercise, because what we will ask you during this session is to evaluate some sequences of video of cholecystectomy. And thanks to our artificial intelligence machine, we can extract a sequence of 2 minutes, 30 seconds, really around the division of the different elements of the cystic pedicle. And we will ask you if you think that the CVS was achieved or not. So this is what we're going to do in the next steps. But before that, I would like to thank all of you. I think there were about 500 people who respond to the survey that was sent yesterday. So it's really amazing, the response rate that we have. And Pietro will comment a little bit these results. Then we will go to Nat Soper to understand the history of CVS, why we're using that, how they develop, why people develop this concept of CVS. It's very important. Then in the third part, we will go to these different video sequences. We will comment at each steps what was the response of the community, of the participants, because at the end of each sequence, you will receive a poll saying, okay, CVS was achieved, yes or no. And we will analyze that with the faculty and comment eventually if there are some problems between the different types of response. And at the end, Pietro will give a very brief lecture on the potential of artificial intelligence in this very important problem. So I'm moving towards Pietro because we will look very rapidly at some nice information about the survey that we ran yesterday. Pietro, thank you.
I'm super excited to speak about this very important topic to me. So let's see very quickly who we are. So as Rita was saying, we are more than 700 people connected from all over the world. As you can see, most people come either from Mexico, Italy, or the UK, but it's really, really sparse. Most of the participants are either resident or consultant with different level of experience, and most come from public practices, either academic center, 20%, or public hospitals with no teaching, 60%. But let's see what's our experience with bile duct injury. So 50% of the respondents to the survey experienced a bile duct injury during their career. And 30% of them experience a major bile duct injury, so the complete transection of the common bile duct. The respondent thought that less than 20% of general surgeons along their career usually experience a bile duct injury. However, according to recent surveys, actually in between 50% and 80% of surgeons experience a bile duct injury in their career. And let's move to the critical view of safety. So you defined the critical view of safety correctly in about 55% of the times. So just to be very brief, but then Professor Soper will walk us through that. The clear vision of two tubular structure entering the gallbladder, a dissected hepatocystic triangle showing the lower third of the cystic plate divided from the gallbladder. So even though you were right with the definition, 37 of you suggested that actually to verify the critical view of safety intraoperatively, you should see a funnel-shaped structure originating from the gallbladder neck, which is actually closer to the infundibular technique than the critical view of safety. Then why do we have to achieve it? 52% of you responded correctly to avoid bile duct injuries due to the misidentification of anatomy. Finally, we wanted to see what do you do when you cannot achieve the critical view of safety, which happens very often. And the large majority, 46% of you bail out to a fundus first cholecystectomy, and 32% of you do a subtotal cholecystectomy. What is best is a matter of fervid scientific debate at the moment. Finally, how do you document, both for yourself, for your trainees, but also for patients and for medical legal reason, the critical view of safety? This is quite nice to see that 23% of you describe the 3 criteria of the critical view of safety in the operative report, and about 15% use video for documentation, besides the 10% that use the suggested doublet view photography. With this, I conclude. Thank you very much.
Thank you, Pietro. So you can see that we have a lot of subjects to discuss: definition, use, bailout procedures, etc. So before moving to Nat, he knows that it's a quite challenging task to present the concept of CVS, and but I think that it's very important to understand why we're focusing on this technique. So Nat has moved from different place, and from Chicago. He is now chair of the Department of Surgery at the Banner University Hospital in Phoenix, Arizona. And it's a really a great pleasure for me to have Nat with us, because as I was saying, he's a longtime friend, and is an expert in the CVS. And I think it's very important to have his introduction by this lecture defining exactly what we're talking about. Thank you, Nat.
Well, Bernard, it's really a pleasure to be here. I wish I could be there and staying in that beautiful new hotel that you've just opened, but maybe someday we'll be able to do that again. And it's very nice of you to ask me. Here in Phoenix, it's morning, and it will be very sunny and quite warm today. So I'm looking forward to that. So let's get started and talk about the critical view of safety. So the critical view of safety is something that we thought about many, many years ago. And it was as a result of the rash of bile duct injuries that we were seeing shortly after the introduction.
Can you share your screen?
I will interrupt you. We don't have your screen.
You're kidding me.
No.
Okay, we'll try it again.
It's coming. Yes. Large screen if you can.
Display settings, swap.
Yep. Are we getting it now?
Yeah, I think that we are in. Yes, excellent. Thank you.
Sorry about that. Despite practice this morning, it shows what a Luddite I am with new technology, and that I'm a digital immigrant, not a digital native. So anyway, sorry about that. So the risks, we saw that there were a number of bile duct injuries occurring, and we thought we needed to do something about it. So I think we have to start at the beginning. What are the risk factors for bile duct injury? Training and experience, of course, the stage of the disease, particularly how much inflammation there is, if there's intraoperative hemorrhage or other things that impair your view, aberrant anatomy, especially right hepatic ducts that come right near the gallbladder, and many surgeons are reluctant to perform intraoperative cholangiography or ultrasound to look at the bile duct during the operation. But I think most important is the dissection technique, and that's really what we're going to concentrate on this today. The anatomic hazards are severe, acute, or chronic cholecystitis, the cystic duct being short or inflamed or attenuated, aberrant right hepatic ducts. And what I think is very important is the condition where the infundibulum of the gallbladder is tethered to the common bile duct by scar tissue, and a smaller tented common bile duct. And finally, superficial bile ducts in the gallbladder bed, or the so-called ducts of Luschka, that can leak post-op, but those aren't major bile duct injuries. To show a couple of cholangiograms, this shows a very short cystic duct, and clearly there would be some risk of an injury if you weren't aware of this. And second is a long parallel cystic duct going along the common bile duct. And again, you could imagine putting a clip across both of these structures. And finally, an aberrant right hepatic duct where the cystic duct comes off the right hepatic duct. And this one happens to contain stones. We were worried that there were stones present. And this is the so-called tethered infundibulum in a cartoon form. So the direct causes of bile leaks and biliary injuries are the most common problem leading to a bile duct injury is misidentification of other ducts as the cystic duct. It could be the common bile duct, the common hepatic duct. It could be an aberrant right hepatic duct. There are many other technical causes that can cause injuries, but these usually cause more minor bile duct injuries rather than excision of the ducts, which is the one that we really worry about when performing cholecystectomy. So how can you avoid duct misidentification? I think it's important to use an oblique viewing laparoscope so you get different views of the operative field. I think in the dissection technique, when I'm working with a resident, I say we start the dissection on the gallbladder wall, not anywhere else, but on the gallbladder wall, usually about a third of the way up, and do an abbreviated top-down technique, not starting up at the fundus, but on the body of the gallbladder. You need to have the correct direction of traction, and you need to move it back and forth so you get a three-dimensional view of the situation. And you need a complete dissection of the hepatocystic triangle. I often will use low energy cautery and a lot of blunt dissection in this. And you must attain the critical view of safety after elevating the gallbladder from its bed. And I truly believe this is the most important component that can avoid bile duct misidentification. And finally, I think we should liberally use cholangiography or ultrasound or maybe the newer techniques for looking at the bile duct intraoperatively if you're not sure. Now, certainly in France, I'm sure you guys talk about the triangle of Callot. Well, Callot in his doctoral treatise talked about this, but if you notice how it's drawn, it's actually a very small triangle with the hepatic duct, the cystic artery, and the cystic duct. But most of the time when I'm operating, these two structures don't come together like this, and it's a very small triangle. What we think you need to dissect is the hepatocystic triangle. Along the liver, you dissect the gallbladder wall away, and ultimately you'll dissect the cystic duct as well. And you can see that Callot's triangle is a very small portion of that entire hepatocystic triangle. And then the traction is very important during much of the operation. We'll pull the infundibulum to the patient's right and inferiorly and pull the fundus of the gallbladder superiorly and laterally to disalign the cystic duct from the common bile duct. But then we also feel it's important to so-called wave the flag, move it back and forth, and look at the opposite side, the reverse view, and dissect from this side as well, so you can really appreciate the three-dimensional anatomy of the gallbladder wall, which can look something like this. And what was mentioned earlier was the so-called infundibular technique. Now, infundibulum is a funnel, right? And so what you see is, if you see a narrowing of the gallbladder down into this funnel and think, well, that must be the cystic duct. Well, the problem is that if this part of the gallbladder is tethered to the common hepatic duct, what you really have is the common bile duct, which is that funnel and not the cystic duct. And this is a visual deception inherent in this technique, and why you really should not use this technique for dissection. Because again, as we reported in 1993, this is really an area that's vulnerable to damage. So the critical view of safety itself is a view following the dissection. The necessary components of that view to really be authentic is the hepatocystic triangle is cleared of tissue. The lowest part of the gallbladder, we say usually the lowest third or quarter or something like that, is separated away from the cystic plate or the bed of the gallbladder, and two structures and only two structures are seen entering the gallbladder. And this is the cartoon of that with the necessary characteristics of the critical view of safety. And this is what it looks like in real life. So is there evidence that there is value in dissecting to the critical view of safety? And the answer is we don't have good level 1 evidence with prospective randomized trials. It's been estimated that given the rate of bile duct injury, it would require 4,500 patients in each arm of a prospective randomized trial to really show a difference between the infundibular view or the critical view of safety. There have been several series that have suggested that if you do the critical view of safety on a routine basis, you can avoid major bile duct injuries in large series. And the Dutch Society of Surgery has adopted the critical view of safety as the best practice guideline. We're still awaiting results of this policy to see whether or not there's really a difference in that Dutch society. So that's all I have this morning. I'm really, again, happy to be with you and hope that we can really get to the heart of this and talk about the important components. So thank you very much.
Thank you, Nat. I think it's a very nice introduction and a very nice summary of the CVS concept. And as I was saying, very important to understand why that was developed in the early days of laparoscopic cholecystectomy. So we are back in the early 90s, and it's true that at the time, probably each of the surgeons who was studying laparoscopic surgery got some problem with the bile duct. So that's why Nat and the team developed this concept of CVS. So this is a good introduction. And now we're going to start the practical session. And I'm the one who will run the video. So as I was saying, I will give you videos that we have selected, and you will see the phase of dissection of the hepatocystic triangle before cutting of the artery or the cystic duct. So usually the recommendation is to get the CVS before doing that. So that's, as that is saying, we have really to analyze this phase of the surgery, and that's what I'm doing. So you will watch that, and this is real-time image, so no cuts. It's just the time needed for the dissection. And at the end of this sequence, we will send you a poll, and you will see, you will say, okay, CVS was achieved or CVS was not achieved. It's too long to describe why, etc. And then we will look at these results with all the faculty and comment a little bit why it is or why it's not, okay? So this is the principle, and we'll see if it's gonna work. That, as I was saying, is a first experience. So I will start with my first video. So I don't know the videos. Pietro select these videos, and this is the first one. So I won't comment. I think it's a quite nice picture, nice dissection. So the question is that for you, are you considering this CVS is achieved or not achieved for any reason?
I got to admit, it looks pretty good to me. The artery looks a little bit flimsy, maybe cauterized. It looks pretty good.
So voting for the audience, yes or no?
I guess I should talk later.
We cannot vote, so.
I keep trying. I know it's frustrating, but we can't.
No. We skip the button for you. Okay, we can stop the video and we can show the results of the poll. It is yes in combien? 88%, no in 12%. Very interesting. If one of the guy who put no can just write on the Q&A to Rita, so we will understand why they think that it's not a CVS. And I would like to ask to Andrew, because he started, and then Nat, what do you think about this first video?
It looked pretty promising to me. It looked pretty clear. Like as I said a little bit early, the artery looked a little bit beaten up, a little bit cauterized, but I think that's a very nice dissection.
Nat?
I believe it was achieved. I would have liked the image, the surgeon to pull the infundibulum to the patient's left to show us the backside as well, because I couldn't see clearly that you could see the cystic plate, but I think it was a good critical view of safety.
Okay, so good. Rita, no comment?
Yes, we have a comment, anonymous, that it was no, because there was no posterior view.
That's right, Nat. That's what you're saying. I mean, usually
Yes,
when we're establishing the critical view of safety, we should look in the front and in the back. So this is really the rules for a correct CVS. Of course, here maybe in the minutes preceding this 2 minutes and 30 seconds, maybe the guy did it. But obviously on this video, we could see that the cystic plate, 2 structures, and a good dissection of, maybe too much dissection of the hepatocystic ligament. So first one looks okay. So then we will discover the second one. I don't know what it is. Pietro, select that.
Bernard, are these your cases?
I guess he doesn't want to own up to it.
From the surgical department for different reasons, including medical legal reasons. And majority of the gallbladders are done by chief residents, etc. Some of them are probably done by some senior surgeons. Am I right, Pietro?
Yes.
So that's the day-by-day procedure. So we're waiting because we don't know what's next.
I think we could probably vote.
Yeah, it cuts. So, okay, we can send a poll. So the same for the previous one, yes or no? So you see that in our institution, we have scissors that doesn't cut, but even with a scissor that doesn't cut, you can put your patient at risk. Okay, so I think that we can go to the poll, to the result of the poll. Okay, no, 94%. And 6% yes. So Nat, comment?
It was clearly, the CVS was not achieved on that one. Maybe safe to clip and divide, but boy, that would make me nervous. And so I would think that much more dissection needed to be done.
So none of the criteria were achieved, if I'm right.
None of the criteria were achieved. The gallbladder had not been taken off the cystic plate, and there was all kinds of tissue still in the hepatocystic triangle. So, you know, I wouldn't have felt comfortable clipping at that point.
Andrew?
Yeah, I saw too many structures going into the gallbladder. I couldn't tell what. There were certainly more than 2 structures that you could argue were going up to the gallbladder. I don't think it was achieved.
Pietro, some comments?
Well, clearly not achieved. I cannot add much on who proposed this in the first place.
Some comments, Rita?
Regarding the video, no.
No? Okay, so that's good. It's easy. Pietro, your selection is very easy.
And this is to warm up. We will see next videos.
Okay, another one.
Very slow application. No tension on the tissue. Double clip, they don't cross themselves. They have a complete control of the little vessel. And now I can cut the cystic duct and the cystic artery. Okay. I will cut the artery first. Okay. Very conventional scissors that cut in a very bad way.
Okay, so I think that this one was done by a senior surgeon, a staff surgeon of the department. So same question, yes, no. And we can start with some comments from Andrew.
Well, I mean, that was a very nice dissection. I saw a few extra vessels, but they look like veins. So I'm not sure if technically CVS was achieved, but I certainly would have proceeded as the surgeon proceeded.
Nat?
I think it was likely safe, but I would have had my resident do more dissection, particularly on the posterior aspect, because it looked like there were a couple, at least one more branch of the artery coming up posteriorly, and certainly was not a quarter or third of the gallbladder taken off the plate. But again, I think it probably was safe.
Yeah, interesting. 68% say yes. So 34% say no. And indeed, I remember this video because in our research program, sometimes I'm called by the fellows to be the moderator when there is some discordance between the evaluators of the critical view of safety. And I remember very well that Pietro came to me and said, I don't think it's a critical view of safety is perfect because there is not enough dissection of the cystic plate. So the question when we're working on that, it's we've seen that systematically when we have some discordance between report or from operative report, etc., and the video, is in the majority of the case is the cystic plate dissection. So Nat, I would like you to comment a little bit on what is the amount of division that we have to get. Should we do it on half of the gallbladder, 1/3 of the gallbladder? This is a non-parametric parameter and it's very difficult. So what is your opinion on that?
Well, what we've said in publications is you should have a quarter to a third of the gallbladder elevated. And there was another comment that I saw come up, and I agree. That cystic duct was pretty wide. That would have made me a little bit nervous too. I would have wanted to do a cholangiogram or something to look at the bile duct. But yeah, so we say a quarter to a third. It's never been looked at with a prospective randomized trial or anything else. So hard to know. But again, I would have done more dissection on that patient. You're muted.
Andrew, also, you are a little bit concerned by the size of the dissection from the cystic plate, no?
Yes, no, of course. I saw a few extra, they look like vessels, even some running with the cystic duct, and then there was the artery behind. And then posteriorly, there was either a vein or an artery coming up. So I would have liked a little more information before cutting, but I can certainly see that what the surgeon did was safe. Okay, and so you think that this information would come from extension of the cystic plate division, no? I'm a big fan of dissecting quite a bit. I do it at least a third to a half before I start to cut things, you know, when I can. Big fan of that. You always find little surprises every now and then. Oftentimes there's a posterior artery, which I almost look for routinely. You know, sometimes it's about 2 to 3 centimeters away. I seem to find it on half of my gallbladders at least. So I like to identify also that vessel before I start cutting things.
Okay.
No, I agree, Andrew. And you're going to have to do that dissection at some point anyway. So
Yeah.
why not do it before you cut and clip and cut anything?
And regret it, right?
Exactly.
Rita?
Yes, we have a comment in this video regarding the size of the cystic duct that was remained, that in this case was kind of long or large. What do you think, like in a post-operative symptoms or complications?
That's always the big question, because Nat and me, we are all surgeons, so we were taught to start the dissection and leave the smallest part of the cystic duct on the common bile duct in open surgery. Then when we move to laparoscopic surgery, we go back to the gallbladder side. So Nat, can you comment a little bit on the importance of the length, short, long of the cystic duct, and what is the potential consequences of leaving a long cystic duct?
Well, I don't think you need to dissect all the way to the common bile duct. I think that is probably dangerous in many people's hands. What I tell, again, with the residents dissecting, we will dissect out the critical view of safety, and then we'll dissect enough of the cystic duct so that we can easily put the 3 clips on. That's what I tell them to do. I don't, and the other thing that I always do is, before clipping distally toward the common, I'll usually put a clip on the neck of the gallbladder. Then I'll have them incise the cystic duct and milk it, looking for stones in the cystic duct. Because we wrote a paper years ago showing that the indication for common bile duct stones was strongest if there were cystic duct stones, even stronger than the diameter of the duct or pre-op bilirubin or anything else. And then if I see stones in the cystic duct, we'll do a cholangiogram or something to actually look for them. But certainly with that thick of a cystic duct, I would have done something more to look for common bile duct stones or for stones in the cystic duct.
Andrew,
I'm sorry, I saw someone had a comment with the milking of the stones, which you just mentioned, which is something always nice to do routinely. Even before you've cut anything, sometimes you can feel or you can see movement. It can give you more information.
Yeah, I think it's interesting for this reason, but also starting with the clip on the gallbladder side and open a little bit, it's just a confirmation that you're right. I mean, you know that it's a bile duct, so it corresponds to your picture of the scene. So that may help sometimes if it starts to bleed, you have to rethink a little bit the way you made your dissection. So it's a very good trick to start with that. Yeah.
And Bernard, I also want to respond to a second part of your question, and that is there a problem with leaving too long of a cystic duct? And the answer is probably not, as long as there are not stones in it. And you know, when people start doing subtotal cholecystectomies and things and leaving some of the infundibulum, again, if there are stones there, I've done at least 10 second lap choles on people sent to me where there have been stones left behind, and it forms a little gallbladder and they can get, you know, symptoms again.
Okay. Rita.
We have a lot of questions. I will try to summarize because we have seen different type of dissection, and regarding the energy that we use, if we dissect the cystic duct and the artery with a Maryland or hook, where is the setting? What are your recommendations? And also about, in case of important inflammation, if you recommend to do any type of cholangiogram and the use of fluorescence in this setting, your experience.
That's a huge discussion. So we will share. I think that briefly, Andrew, fluorescence is promising.
So I like to use fluorescence when I do more complicated biliary surgery. Hepatectomies and Whipples and things like that, I don't find it particularly helpful in gallbladders as of yet. It's very, at least at my hospital, it's cumbersome to inject. You have to change the camera. I think if you have a high suspicion of having a complicated surgery. Personally, I would just do a cholangiogram. I'm not, you know, I've rarely had an indocyanine dye really bail me out of a rough situation. I have to go to cholangiogram.
Yeah, you have another problem. You are in France, so we're not allowed to use ICG.
Oh, really?
No. Second question: what tools are you using for dissection? You using the hook or a Maryland dissector or whatever?
So I like to. It really depends on the gallbladder. I like to use the Maryland, but at my new hospital in France, we don't have a Maryland. So I like blunt dissection. The best is the safest. You know, I do like to use the cautery. Do like to use the hook, but I can also use the bipolar. I really don't like to use the same instrument every time. I really like to tailor it to the patient's needs. Sometimes the tissue just doesn't cut as well with the hook, and sometimes you need a finer dissection and you need the bipolar. So that's why I can't give a clear answer.
Okay, so you're a little bit French now because you're using a bipolar.
Yes. Well, I trained with Gaillet, so yes.
Yeah. So not the same question for you. First, fluorescence. Second, the tools, the instruments.
So we have not used fluorescence for the same reason that Aaron was talking about. And I think it's clumsy, and I also think that the data, yeah, if everything is clear, you probably don't need it anyway. And when everything is very inflamed or very thick and fatty, it probably doesn't help you. So in fact, I usually do intraoperative ultrasound of the bile duct to look for stones and things. And that's the other thing with fluorescence, it doesn't show common duct stones, right? So the ultrasound is even better for looking at stones. It also helps sometimes in very difficult cases. At the very beginning, if it looks like a bomb has gone off, we'll go find where the common bile duct is, and then you have some idea where your dissection planes might be. In regards to this dissection technique, I've used low wattage hook cautery forever for much of the dissection. And I'll use the Maryland as well, sometimes use the peanut or whatever bluntly. And the other thing I use a lot is the suction instrument. Yes. Irrigate a little bit and use the suction as a blunt dissector. And I think that works really well as well.
Okay, thanks. Just to let the participants know that if you're going to WebSurge, I remind you that WebSurge is free of charge. You don't have to pay anything. If you're going to WebSurge, there is a state-of-the-art recent update looking at all the application of ICG fluorescence. So my recommendation is to look a little bit around that to give another opinion maybe and to see some videos also. So I think that we will move now. Rita is collecting a lot.
We have a lot of important questions. Also, one that has came is that the traction depends really much in the port that which are placed, no? So in this case, how is the port setting and which are your recommendations to achieve a good critical view of safety?
I think it's a very difficult question because we know that we are in the United States or we are in Europe or we are in England. Port placement is different. I think really to summarize, you have to create triangulation, no matter how you do it, and one grasper for retraction. And when we made the survey in the different courses that we're running, everybody is using 4 ports. That's the main recommendation, is to use 4 ports, because if you can't, you have 2 hands, you have 1 head with the camera, and you have 1 retraction. This is what we recommend in all our teaching programs. So I just asked to Andrew and Nat if you also recommend the 4 ports technique.
After you, Nat.
Okay, Andrew, thank you. I've always used the 4-port technique. I mean, we did some, we were part of a multi-center trial looking at single incision laparoscopy for cholecystectomy. And number one, I found that not very satisfying in terms of what the dissection looked like and the angles and things. And second, the result of that showed that there was not much of a difference in terms of outcomes, except it took a little bit longer to do, and there was a greater incidence of incisional hernias around the umbilicus at 1 year post-op. So, and the difference between 3 or 4, I think 1 5-millimeter port, or even if you use needlescopic things, that doesn't make any difference in terms of postoperative pain. And so I feel that the safest thing and the easiest thing is to use a 4-port technique. And I tend to use the American positions.
Okay, Andrew.
So I have done notes cholecystectomy in the past. I've done single port in the past. When I do single port, I like to use 4 trocars, 4 instruments, absolutely. But I must admit, I do not like the single port anymore for the hernias. It just doesn't make any sense to me. Also aesthetically, every now and then you can put everything in the belly button on a beautiful patient. You could maybe use the argument, but I do it very rarely now. But I do sometimes try to do a decreased port cholecystectomy, but only on the simplest of gallbladders. I really think if you ever have an injury and you have not used 4 trocars, you're just not going to do well in the court in front of a judge. So I'm a big fan of 4 trocars.
Okay, that's a good message. So we're moving. So that's the third one. Number 3? Cat? No. We've shown 2 videos, no? 3. So I have to go to 4. Cat. I put cat. So this is number 4. Okay, can we have the results of the poll? 50-50. And I just want Pietro commenting on that because we discussed that. And he's organizing the sequence, so he has some ideas behind that. Okay.
So for me, this case is quite interesting because if you look carefully at the level of the cystic plate, here the dissection, even if the video is not really very well visible, is slightly larger. And there is what I think is a right hepatic artery running on the cystic plate. And if you don't do a large dissection of the cystic plate, for instance, like in the previous case, you could have missed that, which can lead to adverse events. I don't know, but I will let you comment on this. For me, it's a good example compared to the previous one.
Yes, Nat, some comment?
No, I agree. Again, it drives me crazy when before the clip, they don't show you the posterior aspect of that. But I don't think there was enough dissection of the cystic plate. And even from the anterior view, it looked like there was a branch, like potentially a right hepatic artery, that they were maybe even clipping across. It was hard to tell. When they pulled it up after dividing, you could see there still was a branch coming up nearby. But I would say that the CVS had not been achieved due to the inadequate dissection of the cystic plate, particularly posteriorly.
Excellent. Rita, because we have hundreds of questions.
Yes, we will try to summarize. Regarding the clipping, what do you think about M-locks, metal clips? And do we have to put double clipping in every case? And also we have an important question that has been posed that regarding when it's really inflamed the gallbladder and you cannot grasp, what is your advice?
Okay, we will answer the second question when we will move to some more complex cases. Just a question of the clip, Andrew.
I'm really okay with either clip. I think I prefer the metallic clip, but I'm used to using that in America, but in France, they use a lot of Hemolock. Personally, I think it's better for the environment to use it. I think it's less waste, which is why I like it. But sometimes because of the curve, you can't get what you need. So again, I'm not wedded to either one strongly. And if you have both, I think it's good, and it depends whether you need a curve or you need a straight clip.
Okay, Nat?
Use metal clips all the time.
Yeah, we're using metal clips. Majority, some of the guys are using the Hemolock. I think it doesn't make sense in cholecystectomy because it's quite expensive compared to a reloadable, simple metallic clip applier. So I think that I've used that for 30 years now.
Yeah, exactly.
More than 30 years. And
yeah, exactly.
Visible metallic clip is there? I'd love to see that. Who makes that?
No, it exists. Okay, Rita. Rita is busy. Okay, we can move. Okay, we're moving. Next video. So this is another one. So just for the audience, usually in our institution, when we're using the hook, we're using about 20 watts for the energy, monopolar energy, 20. So very low wattage. And even when you're using that, you see that it works. So we don't need to go very high in the wattage because we know that as soon as we increase the power, we increase the lateral damage. So work with very low wattage. Okay, so you can send the poll. You see the scissors I'm talking about? Okay, can we have the results?
We had the same scissors in America too, don't worry.
That's a French company. 47 yes, 53 no. Nat, you are the judge.
It's driving me crazy that there's not more posterior dissection that is viewed, or pulling it to the right. I think, again, not enough cystic plate was shown on that. I think is the bottom line. I think it's likely safe. I think the likelihood of bile duct injury there is pretty small. I also didn't like the technique of dissection, kind of poking a hole through instead of doing a big dissection up the plate first. But when he or she pulled it down there, you can see, I think there are only two structures coming across. But again, I just don't think it's an adequate dissection of the cystic
This is a
plate.
little bit blurred, okay, on the cystic artery. We don't know exactly, this zone is not very clear, I feel. You see, here around. Ouais, c'est trop difficile. Okay, Andrew.
Well, you guys are tough, that's for sure. I thought it was a pretty nice dissection, but I was in pain watching that sharp object with coagulation. For sure, I'm realizing I do a lot more blunt dissection than that particular case. Again, a beautiful dissection, but I was getting chest pain as I was watching it. So I would have liked more dissection also.
Rita.
Yes, I don't know if we will have more videos about acute cholecystitis and important inflammation, but something have been posted about Miritzi syndrome and how do you manage when the gallbladder is really inflamed.
Okay, we go towards that, if I'm right, Pietro. Okay, so I have to get out of this. So next, promising. Tubes everywhere.
Big tubes.
Yeah.
You getting chest pain again, Andrew?
I already had a heart attack a few 30 seconds ago.
No, 82%. Interesting, because I think that Nats will confirm.
Yeah, my usual criticism of posterior view and not enough dissection of the cystic plate. And it looked as though there was only one structure going up to the gallbladder. I'll never forget the first time in my experience when I couldn't find a cystic artery going to the gallbladder. And I was, almost having chest pain looking for it and spent about 10 minutes finding it. And of course, probably 3 or 4% of the time, they're just small branches that come up and you can take them out with a low wattage cautery and not even know it. But it's always a little nerve wracking when that happens. And the common duct or the cystic duct look a little bit big as well. But I think my main complaint again is posterior view and cystic plate dissection.
Andrew?
Yeah, I know some continents like in South America often take the cystic artery just with cautery, but it was still painful for me to watch, even though clearly the surgery was going very safely, and that they got away with taking the cystic artery with the cautery and there's no problem. But really just what Nat said, I'd have liked more dissection and to see the artery before cutting.
Yeah, this is something that is quite interesting. So again, we're talking about the cystic plate. And as Pietro is saying, is that sometimes you have the feeling that you've got the cystic plate, but this is not the cystic plate.
No.
Okay.
You're right.
Am I right, Pietro?
Of
Right.
course.
The
And
cystic
I
plate
also-
is higher.
Cystic plate is over here. Okay. This is not cystic plate. So very important when Nat Soper is discussing about the extent of the dissection of the cystic plate, this is this zone, not this zone, of course.
Yeah, that other zone we call tiger country.
What does it mean?
Very dangerous. Stay away. Yeah.
Okay, we will add this tiger item to the description of the CVS.
Yeah.
You agree? You agree, Nat?
I agree.
Rita.
Yes, like in this case that we have the cystic duct that is quite of large, what is the use of intracorporeal nuts or endoloops in case you cannot ligate? What is your
Yes.
experience?
Very interesting question. So when you're dealing with very large cystic duct and being sure that it's not the common bile duct, of course, are you relying only on clips or do you have other tricks to control these large cystic ducts?
Andrew, go ahead.
I have a trick. I was going to actually ask you if you've ever done this, but I've had to use staplers before.
Staplers? In the United States, not in France.
Well, no, in the United States. So for very large cystic ducts, I mean, enormous ones, just use a stapler for sure. I mean, I'm never happy when I have to do it. I like to do a cholangiogram just to make sure I'm seeing everything. And actually, I like to dissect the entire gallbladder off of the liver. I mean, again, I'm not even sure I should be discussing this for this part of the lecture, but sometimes when you have a cystic duct that is as big as your thumb, I don't like to use endoloops, and I can count on my hand how many times I've had to use a stapler, but I've definitely had to with good result.
Nat?
But yeah, I don't advocate that.
I was just going to say, I've never used a stapler on the cystic duct. I've seen one major bile duct injury when somebody used a stapler and what he thought was the cystic duct. I will use endoloops relatively liberally if it's a fat cystic duct or if we've done a cystic bile duct stone removal or there's a lot of inflammation in the area. I'm not sure I trust just the clip. So I'll put a clip there and then divide it and then try and put the endoloop on the common bile duct side of the clip that I've placed distally. And I feel much better then instead of just relying on a clip. And somebody had asked about one or two clips, and the bottom line is I don't trust clips. So I always put two on the stay side and one on the go side.
Yeah,
So
I think that the number of clips is depending on the type of device that you're using. When you have automatic reloader, you use a lot of clips. When you have to get out and in, people are using less clips. That's what I've seen.
So just to remind the people that are listening, I'm a HPB surgeon, so they call me for difficult cases, which why I'm used to using the stapler. But I want to tell everyone there was a case I know of where they used the stapler and they came across the entire portal triad, and the patient did not survive. So I don't recommend, non-HPB surgeons to use the stapler.
Not a routine use.
No.
I've seen it also, and probably not. We've seen the same videos, the guys going through the liver with the stapler. So in our unit, we're using the endoloop, never using a stapler. Okay, Rita, we can move? Okay, Rita agrees, so we move. Next. We don't have the. No, we don't have the. Okay. Okay, interesting because we were discussing with Pietro, of course. So I just want to have first your opinion. We're starting with Nat.
So I think you saw at the very end there, the surgeon was doing more dissection up underneath the gallbladder because clearly there, he had not dissected the point where there were two and only two structures going to the gallbladder. There's at least a third one there. And he barely got into the cystic plate up above, you can see. And again, not seeing the posterior aspect, I think he would really behoove himself to look at posteriorly to see what the dissection looks like as well. So that clearly is not a critical view of safety.
Andrew?
It looks like the right hepatic artery was creeping up. So I understand the difficulty they had. But again, I think posteriorly, if you looked, they might have been able to dissect it down a little bit better to get a better view.
Yeah, what we were discussing is that when you look at the sequence, so no, in 78%, it's right, because this is not a critical view of safety. And in fact, when we leave the sequence going, we can see that at the end of the sequence, he's starting to do what he should do before.
Exactly.
When he's dissecting the zone between what can be the hepatic artery, he's coming back to that afterwards. That's what is interesting. So the dissection was nice, but for me, there was too much tissue there around. This is not clear. And I think that, again, if we're looking at the cystic plate, this is not the cystic plate. Cystic plate is over there. So to expose the cystic plate, it would have exposed this zone. So the triangular, the hepatocystic ligament triangle is not dissected. There are too much structures, and the cystic plate is not dissected. So it's 0, 0, 0. You agree?
Yeah, and that I agree. I think that is the right hepatic artery coming up, which, not infrequently, it'll come right up on the wall of the gallbladder. And if you're not aware of it, boy, it can get very bloody very quickly.
Yeah, it's a very, very nice selection, Pietro, because this is really exposing the potential risk. And even if you have a very nice dissection and you are very pleased with that, I mean, you have really to fit within the rules of the critical view of safety. Means you have to dissect this cystic plate, and to do so, you have to go close to the gallbladder and follow up to the liver bed, and then you will avoid this problem with the potential right hepatic artery. So this is a very good demonstration, a very nice dissection, but not a critical view of safety, and that's a very, very important. Rita.
Yes, we have several questions. In case it's very inflamed, the gallbladder, and you cannot grasp, what do you do? And when do you aspirate? When you decide to aspirate? On the other hand, do we achieve in all the cholecystectomies the critical view of safety, or there are some in which cannot? And what is the relevance of the Rouvier circus in the CVS?
You're muted, Bernard.
Sorry, I'm sorry. I have a problem. We have a new system there. We will address some of this question later because I think probably we have some cholecystitis.
Yes.
Well, and on that last video, actually, it showed Rouvier sulcus really well.
Right.
In
yeah.
terms of where the dissection was in relation to that.
I think that's very important, as you're saying, because people forget a little bit what is this very important information.
There it is.
There it is. So when we're discussing where to start the dissection of the hepatocystic triangle, you have always this landmark. And the rule, this is the sulcus, Rouvier sulcus, and the rule is that you can never start the dissection below the line traced from the Rouvier sulcus to the segment 4 or the liver. So you can never start the dissection there. You should always start above this line from the Rouvier sulcus to the anterior aspect of segment 4. This is a very important information because, again, we could show you some very nice video with nice two structures entering the gallbladder. And in fact, you are far away below the sulcus, and in fact, you are dissecting the right hepatic artery and the common bile duct. So Rovia sulcus is really a very important point to mark the area where you have to work. I don't know if you agree with me.
Well, again, I think that's really a good landmark for if the anatomy otherwise is a little confusing, and or if it's very inflamed, if you can see that, that really helps you to know where to start. But I don't use that as my major dissection tool.
No, of course. Very blurred anatomy. You don't know exactly where you are. We're talking about Mirizzi. This is something that is very interesting, the Rovia sulcus, because you can avoid going on the other side of the bile duct. So it's quite interesting. So we will move to the next one.
Andrew, you do hepatic surgery. What do you think of the importance of Rovia sulcus?
Well, yeah, I don't use it that much. My main issue with my residents is they're always starting too low. I'm constantly getting them to start when there's ever a doubt, start very high up on the gallbladder. You have nothing to lose. But I'm going to start pointing out that sulcus to my residents, see if it helps them.
And I agree with you, Andrew. Always start on the gallbladder. It's the only structure you really know, right? You start on the gallbladder and then work down.
And it's coming out anyway. So if you put a hole in it high, it's, you're okay.
Yep.
This is a very difficult sclerotrophic cholecystitis. You can see the structure. We were talking about difficult gallbladder. This is a difficult gallbladder.
Is that just one clip on the artery?
Okay, we go first to the pole. No, 88%. We're starting to comment on that.
Andrew.
Woo, that was, amazing skills, but I would not have done that dissection like that. It was very aggressive, a lot of cautery, a lot of sharp dissection, and I think a gallbladder that needed a lot more blunt dissection. That said, I was very impressed with how things evolved, but I do not think the critical view of safety was obtained. And I would have opted for in that situation, at most, if he's going to start to cut, a partial cholecystectomy or something like that. But yeah, I would have liked a lot more dissection before cutting things.
Well, I agree. And the other thing that was actually commented on by one of the participants too was putting clips on in a pool of blood where you can't see the tips of the clips is not very safe. Let's put it that way. Now, my guess is that the bile duct was not injured. It looked like a very, very difficult case, but the dissection was certainly not a critical view of safety. You're muted again, Bernard.
Very interesting. So that's why I'm putting again the video, because maybe the sequence was a little bit difficult to understand. And for those who are attending some of my lectures, I'm always showing this video.
Yeah, that's where it hurts right there.
And that I would endo loop for sure.
I can tell you this is a trap.
I think pool of blood should be a criteria for the critical view. If you're in a pool of blood when you clip.
Here we are.
Oof. What
Yes.
was that first structure?
That's where the guy called me. And I came back in the OR and I said, just show me a little bit the big thing that you have cut.
Yeah.
I asked him, show me the common bile duct. He showed me the portal vein. And then we brought the two structures together. So it was a complete transection of the common bile duct plus the right hepatic artery.
Oof.
And in fact, it was identified when we were looking, when he saw this right hepatic artery in the normal position. So in fact, there was no dissection at all between the gallbladder and the cystic plate. And of course, if you're not trying, you won't see it. And it's evident that when I'm showing this sequence, you don't have all the data in your head to understand. But this is just to show that the trap is there, and you can convince yourself, saying, "Okay, it's a large cystic, it's a large cystic artery, but I have my two elements." He was looking a little bit medially, looking at what he thought to be the common bile duct. It was, in fact, the portal vein. And he transected everything and stopped when he was seeing indeed the right hepatic artery and the right cystic artery. And that's where, coming on the liver, that he understood the problem. So it's just to show you a little bit how important is this problem. So you have questions, Rita?
Yes, we have a question regarding what if we perforate the gallbladder and the stones came to the abdominal cavity and you cannot retrieve all of them? What do you do?
Okay, Nat, you can respond to that.
So I think it depends to an extent on the type of stones. If they're pigment stones, they make me really nervous because more than 50% of those harbor bacteria in them. And I've had to operate on several patients, at some period after a gallbladder operation was done and stones were left in and they had abscesses and things like that. And there have been fistulae between the peritoneal cavity and the lungs, for instance, with stones left behind. If they're little cholesterol stones, I'm not as worried about them. But I'll do everything I can to get as many of those stones out as possible. But sometimes it's like caviar and it's everywhere. And, you know, under those circumstances, I just try to irrigate like crazy and get as many of those out as I possibly can. We did a study years ago, literally probably 25 years ago, looking at when the gallbladder was perforated versus when it was not. And we looked at, and obviously we tried to get all the stones, I think we did in the vast majority of cases, but there was no difference in outcomes in those patients who had a perforation or not. And we then surveyed them a year later. And again, there'd been no patient that had a problem related to that. But again, I think retained, especially pigment stones, can be a problem. You need to do everything you can to get them out.
Yeah, I think it's very important. You have to try as much as possible, because in my own experience, in the past, I had one patient who excretes the stone from the back. So if you leave a stone, they will start to migrate, and some people were coughing stones because of migration of the stones between within the bronchus. So you have to clean as much as possible, but as Nat is saying, majority of people do not have any consequences with that. Rita?
Just two comments, if I may.
Yeah.
I had one patient who actually was sent to me with a PET positive liver tumor, and ultimately we worked her up and we took her to the operating room, figuring out that it was just stones. That was
Wow.
be avid, and it was a mess, and whatever. We were able to clean her out, but I don't really understand when the person asks if you cannot remove all the stones, meaning if it takes you several hours, you sit there and you remove all visible stones. You know, I think if you can't remove all visible stones, you just need to spend more time, or possibly convert should be considered. That's why I don't really understand what they mean by you can't remove all the stones. I sit there until I remove all stones that are visible.
Sure.
Personally.
It was also referring that the ones that go through the liver up to the diaphragm, that are like very hard to get. And regarding the last video, that it was like such a difficult case, we have several questions regarding when do you decide to do a subtotal cholecystectomy, when do you bail out and give the patient antibiotics, and when do you decide to convert?
Who's up?
Nat, that's a good question
So,
for you.
You know,
My
like with
question,
everything
I make the question differently. You cannot achieve the CVS.
okay.
Okay, what are you doing?
I was just going to say that is the criteria. If you cannot achieve the CVS, you have to think of a bailout thing that you can do. So, and it ranges anywhere from just stopping if the patient is not, you know, critically ill or septic or something like that, to putting a tube in the gallbladder and just draining it, to doing a subtotal cholecystectomy and leaving a little bit of the infundibulum behind. But if you do that, you have to clear out all the stones, and usually we'll try to do a cholangiogram to prove that you've done that. And then either a fenestrated or a non-fenestrated finish to it. You know, the fenestrated is you leave the cystic duct open, essentially. The non-fenestrated is you try and close it. In my experience, when I've tried to close it, sewing it, the tissue is usually so friable, it's not going to hold anything. And so we usually leave it open, put a drain in, and then if there's bile in the drain, we have an ERCP done with sphincterotomy.
Yeah, I think it's very important. And we had one question regarding the Merizi syndrome. So this is the answer for the Merizi syndrome: is you just leave part of the gallbladder on the liver pedicle, and that's it. So Andrew, what is your bailout procedure? Are you considering some fundus first sometimes?
Sometimes I do. I'm definitely a fan. You know, I was thinking of a patient I had recently, a gangrenous gallbladder. I couldn't get the critical view. You know, so I did a partial cholecystectomy. I was interested in a paper by Strasbourg in 2015, Annals of Surgery. I believe you're probably an author. Beautiful paper, and just discussing the difference between subtotal and partial cholecystectomy. You know, very, very interesting. I tend to do what I think is a partial. I'm a big fan of keeping a fenestrated because I'm worried about creating a neo gallbladder, which I've had to operate on also, which is just a nightmare. But I was interested in what you said, Nat. You like to clear all the cystic duct stones because what I was thinking actually is that oftentimes it'll be occluded with a cystic duct stone, and you can kind of get away with not having a fistula. So if you could just
right. No, what I really meant, Andrew, is trying to get all the stones out of the infundibulum, right?
Okay. Okay.
And if you can, and because that too will probably become a little gallbladder again, right?
No, absolutely.
So, you know, and we try to do a cholangiogram, but if you can't, I'm not going to kill myself, you know, trying to get every last stone out of the cystic duct.
Oh, perfect, perfect. Yeah, I think fenestrated is the way to go. At first, it's very scary, but boy, do you sleep like a baby afterwards. You know, trying to put sutures in that tissue in the shield of what's it called, Omekli? It was in your paper. I was very impressed with the word. I actually wrote it here. Meckelmoil, the shield of Meckelmoil. So, yeah, I definitely like to stay away from that. And fenestrated is a really a beautiful bailout procedure.
Yeah, some people, there were some studies publishing the results when you're trying to close the remnant, or just putting a stitch. If you see the cystic duct inside of this pouch, you can put a stitch just on the cystic. It's quite easy. Maybe apparently on the papers, it reduces a little bit the chance of getting the need for ERCP afterwards. So it's just a stitch and not trying to close the gallbladder to create a new gallbladder. Maybe it's no sense.
Right, right.
Okay. We're moving. Another one.
This is deja vu all over again.
You have a little bit of posterior view, yeah?
Maybe.
Almost.
Oh yeah, it's coming, it's coming.
Yeah, yeah.
And I'll make one comment here while he's doing this, and that is often I will tell the residents, look, you don't have to clip both structures at the same time. It's often way easier to clip and divide the cystic duct first and then be able to pull it up and really see things clearly before you put them on the artery.
Or vice versa sometimes.
Or vice versa, yeah, absolutely.
Okay, we can send the poll. Do we have the results of the poll? No, 75%. Oh, they're becoming very, very strong, huh?
They're becoming very, very tough.
Yeah. So 75% no, and I guess why, but Andrew, you have an idea?
Well, again, the posterior view wasn't adequate for me. More of a dissection along the cystic plate for sure. But you know, clearly a nice dissection, and clearly I've assisted other surgeons do exactly that dissection. But it's better for everyone involved to do more of a dissection.
Yeah, Nat?
I agree. I agree. That's why I said it was deja vu all over again, right? Not enough posterior and not enough dissection up the cystic plate.
Yeah,
but again, probably safe.
Yeah, safe but risky. Because again, this is the cystic plate and this is not the cystic plate. So this is something that people should realize, that cystic plate is a very, very important criteria. Okay, so moving to the next one. I'm discovering with you. So Pietro told me this one. Ah, that's good. So it's not, this is acute cholecystitis, obviously, or subacute cholecystitis, but there is some inflammation. Huh? And this is France, of course, because you see this bipolar.
Think they got disconnected? Yeah.
I think so.
Yeah.
So Andrew, where are you?
So I moved to Paris. I moved about 2 years ago, trying
I did
to,
not.
yeah, trying to escape the madness, but I didn't really realize it would get this crazy.
I didn't either. I
mean,
tell you,
yeah, unbelievable, man.
Wednesday, I was just heartbroken.
Yeah, I mean, irony of ironies, I'm actually in Georgia right now in Tbilisi. And to be in Tbilisi, which has been, you know, has had many civil wars, many problems, and to feel safer and more secure here while watching that is just surreal. Just surreal. And I think it's gonna continue, as you know.
12 more days.
Yeah.
Bernard.
I can't hear him.
Yeah.
Here he is.
Yes, we have problem with the main computer. So you've got this, the full video, the last one.
I'm not sure I saw it.
We only had a small amount of it, Bernard, and then it froze.
Yeah, that's a problem because we have a problem with the main computer. Oui, tu peux donner ta clé pour mettre le film. So we will share on this Q computer.
Il y a un adaptateur.
So Rita, while we are trying to restore this system, do you have other questions? Rita, do you have other questions?
Yes, we have several questions regarding the grasping of the gallbladder. And also, what about if you find a stone that is between the cystic duct and the bile duct? How do you proceed? You try to pull it up, you do a cholangiogram. What is your advice?
Not.
So in terms of grasping the gallbladder, I'll use a tooth grasper if it's a really thick gallbladder wall. If the gallbladder is really distended, I will go ahead and drain it, putting a needle suction into the fundus, hopefully at a place where you can hold on to it with your fundus grasper and hold it closed to be able to manipulate the gallbladder. If you cannot move the gallbladder because you can't grab it, that's a huge problem. So you have to make do. In terms of the stones in the cystic duct, I've talked about what I like to do, and that is make a little incision in the proximal cystic duct. And then what I will have the resident do is take a grasper with the jaws together, go as far down on the porta hepatis as they can, and then sweep up. And I want to see bile come out of that cystic ductotomy. And if it does, you don't have anything blocking it. If it doesn't come out, then I start doing little pinchy things with with a grasper distally on the common duct and then come up the cystic duct. And often you can milk little stones out that way, and then often see free flow of bile, and then you know you're okay.
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 Andrew, you have to add some comments on that?
Yeah, I mean, sometimes you have to start the operation, you have to drain the gallbladder. It's the first thing you do. I mean, with acute cholecystitis, it's, sometimes I have the trocar, and I'll put that trocar right under the right subcostal. I'll stick it right into the gallbladder, and I'll put the suction in right away. And I'll just suction out the gallbladder entirely and then grab it. I don't like to do that, but sometimes you just have to.
Okay.
Maybe we can share the video, no?
You have other question?
Not right now.
Okay, the last video. How do you do
You
that?
select the video.
Just wait a second. We are sharing
Yeah, okay.
the video.
Okay, select.
I think
Okay.
you are seeing the video.
You're seeing the video?
Yes.
Okay.
This is a new technique for me, using the bipolar spreading and doing some cautery with it.
It's nice, huh?
Yeah, it looks like it works well.
This is one of the HBP surgeons working with us. He's, in France, the school of Brice Gaillet is using bipolar everywhere. And this guy was, HBP is also using the bipolar to dissect this very complex cholecystitis. And it works very fine, in fact. And as everybody knows, risk of bipolar is 0. So it's very interesting.
Why doesn't he just use the bipolar to take the cystic artery?
Yeah, should. I'm doing that when I'm not doing that much cholecystectomy anymore, but I was used to coagulate. Small ones, bipolar, it's very safe. On the gallbladder side, no risks.
Now that we are here, we also have questions regarding the ultrasonic device or ligature. Is it better to use under acute inflammation, or it's not a difference?
So I think I can answer that. When I do a lap Whipple, I have to take gallbladder, as you know. And honestly, sometimes I'll have the harmonic or I'll have the ligature, and oftentimes I'll just go to the hook because it's just so much easier. So I don't really see an advantage with the harmonic. That said, it can certainly be used, and it's if used properly, you can dissect. But really, I don't see it as a benefit.
Okay, so what do you think about this dissection? Critical view of safety? Yes, no?
Again, I would have liked to dissect further up. I hate to sound like a broken machine. In that area, in the cystic plate, I really do at least 50% of the gallbladder before I start to cut anything. I just don't see why not. And oftentimes, I'll take the entire gallbladder off of the liver bed before I clip things. So I'm much more aggressive, I think, than what I'm seeing here.
Okay. Nat?
Yeah, I mean, I agree. I don't think I've ever taken the entire gallbladder off, but I go at least a third of the way up on virtually all of the gallbladders I do.
I wonder if we lost them again. Yeah. So it's good to know you're in Arizona, Phoenix. It's beautiful. You couldn't take the Chicago cold anymore.
Couldn't take it anymore. And I tell you, playing golf in January, it's 75 degrees. It's pretty nice.
Arizona is one of the most beautiful states in the United States. It's so beautiful there.
It is. No, we really enjoy it. Bernard, you're muted.
I think we lost them.
Bernard, if you can hear me,
Yes, you can hear me?
now I can hear you.
Okay. So we comment the last video. I think that I think it's quite a large variety of different critical view of safety. If I can summarize briefly, is that obviously Nat is a fan of the anterior and posterior view. That was missing in the majority of these video sequences. So it's probably not a fundamental recommendation of the critical view of safety because it's not included in the 3 main recommendation, but it's a suggestion to improve the rate of validation of the CVS, if I'm right. You correct me, Nat, if I'm wrong.
I think that's very, very correct. And it facilitates getting that dissection done. And you know, anytime you're using a surface imaging modality, monocular, to see multiple views gives you a much better idea of the anatomy anyway. And ultimately, you're going to have to divide that stuff on the posterior wall too. So why not do it early and make it easier for you?
Sometimes I start the dissection posteriorly because it's just safer, you know, oftentimes.
That's exactly what I tell the residents. Where's the safest place to start? And it is lateral.
Yeah, that's what we're seeing sometimes in the young surgeon, is that they are very static when they're doing cholecystectomy. So they got one position and they are pleased with that. They don't want to change the position. And I think that when we're seeing more advanced surgeons, we're seeing a lot of movements with the structure just to get the good landmarks, to be sure of the landmarks, etc. So as Nat is saying, it's very important to move a little bit to get different orientation. Keep in mind that we have a flat screen. We don't have perception of the depth. And the only way to get this depth perception is to move the structures. So this is very, very important. Last question.
What is the role of drains after laparoscopic cholecystectomy?
Okay, so it's something important. So Andrew, drainage in cholecystectomy?
Well, quite only when necessary. I mean, a partial cholecystectomy where you're worried you're going to have an open cystic duct for sure. If I have any spillage of purulent material, if I have stones, you know, I'm pretty stingy with it, but I have no problems leaving it in a gangrenous gallbladder. Almost routinely in a gangrenous gallbladder, I will leave it even if there was no spillage, just because I'm worried about a postoperative abscess.
My question is, leaving a drainage is a mistake, Nat?
Not if it's warranted. And the other situation in which I routinely will place drains is if there's a really nasty gallbladder and it's intrahepatic and you're cauterizing into the liver a little bit. I worry that you could get a superficial bile duct in the liver to drain bile. Not a duct of Luschka, but that's what many people call them when you do that. And I'll put a drain in, even if I'm going to let them go home later that day. I'll put a drain in and an active drain, and then watch it for 3 or 4 hours for bile appearing. And if there's no bile, you can take it out. Many of those patients are sick enough, we'll keep them overnight, and then I feel better leaving it in overnight. But rarely do I leave a drain. I agree with what Andrew said about you do a subtotal or something, you have to leave one. I agree with a gangrenous gallbladder. It makes sense to put one in. But, you know, of all the gallbladders I've done, maybe 3 or 4%, I end up putting a drain in.
Okay, so that's a good summary. Time is passing. I enjoyed that. I don't know if you guys enjoy it also, but we have to go ahead and really just to finish this session. First of all, I would like to thank Rita for the nice work because she had hundreds of questions. And now we're moving to Pietro, who will give rapidly an overview of the potential of artificial intelligence in dealing with this very complex situation. As we can see during this discussion, it's not very clear sometimes if we have achieved or not achieved, etc. So how can we help the surgeon doing surgery? This is really the aim of the work of Pietro. Pietro?
Thank you very much, Prof. Do you mind if I take off the
Sure,
mask to
go ahead.
present? Thanks. So I'm super excited to have joined this masterclass. I've been working on this topic for the last 3 years. And to me, it's very illuminating to hear this expert discussing. So I'm gonna be brief and walk you through our journey in surgical data science for safe laparoscopic cholecystectomy. To start, what is surgical data science and why do we need that? Modern surgery is becoming complex. Very effective, of course, but if you think about that, you are playing with a team of highly specialized people, understanding and capturing signals from highly technological device, and all of that in a matter of seconds to act on your patient. All of these can go wrong quite easily. And just to give you a figure, 65% of medical error are estimated to happen in the operating room. Analytics, from standard statistics to what today we call artificial intelligence with machine learning and deep learning, can help us model the socio-technical process of surgery and making sure that the right information is delivered to the right person at the right time. And this is the vision that motivated surgeons and data scientists in this institution, as in others, to join forces in the novel field of surgical data science. But let's get practical to the topic of today, bile duct injury in laparoscopic cholecystectomy. So this is the accepted rate of the incidence of bile duct injuries in laparoscopic cholecystectomy, spanning from 0.3 to 1.5% in some registries. This might seem a little number, but however, if you put that in the context of the number of laparoscopic cholecystectomy, more than 1 million per year in the United States alone, this translates in a large number of bile duct injury. And if we accept that kind of adverse event rate in other industries, in other high-stake industry, like for example, aviation, we would have to accept about in between 4 and 20 crashes, plane crashes a day only in Heathrow. So we have CVS, we have heard a lot of it, about it. So why do we still have bile duct injuries? Well, for a number of reasons that have been highlighted in the literature in the last 30 years. Unfortunately, not many surgeons actually do the critical view of safety. Many say they have done it, but actually video-based assessment have found the actual rate of critical view of safety achievement is between 9 and 40%, depending on the series. As we've seen, it's difficult to assess, especially in its non-metric criteria. So the quality of the dissection of the hepatocystic triangle and the amount of cystic plate that needs to be divided from the gallbladder. And consequently, the reporting of this maneuver is not reliable, as many studies have found. So these are the 3 main issues that we have tried to tackle together through a mix of clinical and more technical studies. So let's start from the clinical studies. So we want to promote the clinical uptake of the critical view of safety. We looked at cognitive aids like performing a timeout. These are commonly done in other high-stake disciplines, for instance, climbing or aviation. You double check with your partner safety measures. We called this study the 5-second rule because we asked surgeons in the department to pause, to time out for 5 seconds, very brief, before dividing the cystic duct or artery to double check with their assistant the 3 criteria composing the critical view of safety. Then in this before-after study, we collected all the clinical data, thanks to Rita, and the videos of the procedures performed in the year before and the year after this quality improvement intervention. And then we used a validated protocol to video assess the critical view of safety in double in each video. And these are the results currently under review in a major surgical journal. The red vertical line marks the day of this 5-second rule intervention. So when we went to the department asking to do this intraoperative timeout, and the dotted blue line marks the average CVS achievement rate before and after the implementation of the 5-second rule, while the continuous blue line gives you a percentage every 15 procedures. So what we have found that doing a simple intraoperative timeout almost triplicates the rate of bile duct of achievement of the critical view of safety. So we moved from about 60% to 45% at 1 year. But as you can see, this was highly effective soon after we went to the department, and then it declined a bit over time. Right now, we're working hard in order to develop an intraoperative systematic reminder to implement this critical view of safety. Then we wanted to develop a deep learning system, an artificial intelligence system, that it's able to assess the criteria composing the critical view of safety and highlight the relevant anatomy automatically in a deterministic way. To do that was quite a big effort. We collected more than 200 laparoscopic cholecystectomy performed by more than 20 surgeons. We extracted and annotated in double more than about 3,000 images. And we further manually highlighted the anatomy in a subset of 400 images. Then the computer scientists working within the CAMA lab, directed by Professor Nicolas Padois, designed and trained a network to first segment the anatomy and then classify each one of the 3 criteria as achieved or not. And these are the qualitative and quantitative results that just appeared on the Annals of Surgery. The first row is the input image, and the second row is what you get out of deep CVS. As you can see, a very good number of the images we've used are complex to judge. So just to give you a very brief overview, we decided to do this automatic segmentation, semantic segmentation of anatomy for 2 main reasons. One is to guide the artificial intelligence to understand where to look at in order to assess the 3 criteria. And the second, more clinical reason is to give a visual feedback to the surgeon, so to help the explainability of what has been assessed by the machine. Now we're working very hard to scale to videos with the help of Nariaki Okamoto and Alan Garcia. Finally, why do ping pong players and most sportmen and sportwomen can video review their performance, but surgeons don't do that efficiently? There's not too many institutions that have the logistic necessary to record and review every procedures in its entirety. So we developed EndoDigest using a mix of deep learning and more old school system, a rule-based inference system. So basically what we do, we take models developed at CAMA that are able to understand what is the phase of the procedure and what instruments are being used. By surgical knowledge, we know that to clip and cut the cystic duct, you need to be in a certain phase and use certain instrument. We elaborated a number of rules, and we create a hierarchy in a development set. And these are the results that were very recently accepted in Annals of Surgery. So this is how the machine works in order to make it easier to understand. It analyzes the phases, the blue line, and the instrument usage. Then, for instance, in this case, the machine understands that first you use a clipper, then you use a scissor, and you are in the clipping and cutting phase. So it infers that that's the good sequence of video to use to do concise video documentation of the critical view of safety. And I will skip this because you have seen these 2 minutes and 30 seconds long videos up to now. But just to give you an idea of the results, we tested the platform on 100 unselected videos. Some of them lasting more than 4 hours, so also very nasty procedures. And we were able to automatically identify the moment of the cystic duct division with an average error of 60 seconds, which is less than 2% of the video length. Then we did a surgical study in which Takeshi Urade, a surgeon fellow from Japan, was assessing full-length videos. I was assessing the short videos, and then we studied the inter-rater agreement in between us two to understand how informative these short videos are. And we found that in 91% of the cases, the short videos well document the critical view of safety. So with this, I conclude. To wrap up, so far we have devised strategy to promote the clinical implementation of the critical view of safety, the 5-second rule study. We have developed a system that it's able to automatically assess in a deterministic way this critical view of safety. Now it's time to scale to video and to test it out in the operating room. And we have developed this platform for more efficient video review and assessment of the critical view of safety. While we are very happy of the road performed so far, there's still a long road ahead, both for our efforts to translate into the clinical practice. We need multicentric validation, we need first proof of concept and then randomized trial, but also for the whole field of surgical data science to really have value in the operating room. For that, we need more efficient system from the technical side. But I would like to stress that it's also a matter of culture in between surgeons. Surgeons need to be involved because the technique is there and it's quite ready. And surgeons need to play a role in identifying use cases. For instance, for me was Professor Daleman suggesting me 3 years ago to look at the critical view of safety. But also we need to, as a community, develop an ethical legal framework that allows us to deploy this in the operating room. With this, I conclude, and it's, well, it's been super fun. Thank you.
Thank you very much. Thank you very much, Pietro. And of course, we have Andrew, who is the chief editor of the journal Artificial Intelligence Surgery. So you have 30 seconds to comment.
So it's a new journal. The website is being built as we speak, and really the goal of the journal is to look at any time there is a computer between a surgeon and a patient. That is our concept of what artificial intelligence surgery is. It's not just deep learning. It's actually automatic robotics, telemanipulation, and clearly this is the next frontier. We had minimally invasive surgery, we had notes, single incision, we had robotics, and now artificial intelligence is the next frontier. And I hope to see you once the website goes live.
Yeah, excellent. And Nat knows very well Rick Satava. Rick Satava was
he trained me when I was at Yale.
Rick Satava, back in the early 90s, I remember very well, was talking about the future of surgery done with bytes. So this is probably the way that we will discover, you, Nat, and me will look at that. The other guys will do it in the next future. So I would like to thank you to close this session. I was enjoying a lot. Sorry for this technical issue that was related to the internal network, but I hope that it doesn't impact, and obviously it doesn't impact the number of participants. I would like to thank you both because it was really amazing. I don't know what is your opinion regarding this sort of class. I think it's very productive because it highlights that cholecystectomy is a very important procedure, the most common operation in the world, very difficult operation. and we have really to aim to make it as safe as possible. And really all the scientific societies agree today that the critical view of safety is the way to go. So I thank you so much, because I think that your presence was so important to validate all our ideas. Andrew, was very nice to meeting you, and we hope to collaborate again in the next future. I will thank my boss, Rita and Pietro, for the collaboration. It's very important to look at take care of all the participants. And finally, for the participants, I think that Margot, our communication leader, will send you probably a questionnaire at the end of this session, just to ask you about the technical issues, about the vision that you have, the quality of the video transmission, more technical issues, so that we can improve systematically the quality of our educational program. So thank you very much for this long webinar, and I hope really to be able to see you live back here in IRCAD, because that's something that is fundamentally different compared to this system.
Thank you, Bernard.
Thank you very much. Bye-bye.
Thank you so much. Excellent.
Thank you.